Good afternoon, everybody. Welcome to the to our afternoon plenary. We are in for a great talk. I'm Paola Dazzan. I'm one of the co-chairs of this program committee conference. And I have the pleasure to introduce our next speaker. Our next plenary speaker is Professor Ben-Zeev, Dror Ben-Zeev. Dror is a professor of psychiatry and behavioral sciences at the University of Washington, and he's also a licensed clinical psychologist who specializes in development and evaluation of technology-based approaches in the study, assessment, treatment, and prevention of mental illness. He serves as the co-director of University of Washington Behavioral Research in Technology and Engineering Center, BRIGHT, and is the director of the mHealth for Mental Health program, which is a multidisciplinary effort to harness mobile technology to improve the outcomes and support the recovery of people with psychiatric conditions. His innovative digital health work includes the development of illness self-management apps for people with schizophrenia, leveraging mobile and context-aware technologies for assessment of violence and suicidality in psychiatric hospital settings, behavioral sensing and modeling systems for detection of psychotic relapses, social media-based outreach and remote data collection involving people who experience auditory hallucinations, and clinical texting interventions for individuals with dual diagnosis in community settings. Dr. Ben-Zeev research has been supported by a variety of major grants and awards from the National Institute of Health, National Science Foundation Center for Medicare and Medicaid Innovation, Patient-Centered Outcomes Research Institute, Synergy Clinical and Translational Science Institute, Martelwood Foundation, VA Health Service Research and Development, and John Sloan Dickey Center for International Understanding. He has published extensively, both in scientific journals, such as Psychiatric Services, Nature, Human Behavior, BMJ, but also for the lay public in the New York Times. And in fact, his research has been covered by National Public Radio, Wire Magazine, Slate, and The Economist. He serves as the inaugural editor of the Technology in Mental Health column for Psychiatric Services, which is an APA journal. Dr. Ben-Zeev is a regular speaker at national and international scientific meetings, including presentations at the National Institute of Mental Health Directors Innovation Speaker Series, the National Academy of Science, and the White House. So we are very lucky that he's here speaking to us this afternoon. And I'm sure that his lecture will keep you awake. I won't say any more so that I won't ruin the surprise, but I will leave Dror to give his lecture.
Keep you awake. That's a very low bar, right? Okay. So usually we ask you to turn your cell phones off, right, before talks. I'm going to ask you to do something different. I want all of you to take your mobile devices out of your pockets and your purses. Even if you're a fancy schizophrenia researcher, this will not demean you in any way. Please take them out and lift them high up in the air. And that means whether it's a smartphone, a flip phone, I won't shame you, anything that has wireless connectivity. Okay, so take a moment to look around you. That did not exist 15 years ago at all, right? So that is the context and the backdrop for this talk. We are all alive to witness and be part of the fastest adoption of technology in recorded human history, which is quite a thing. The devices and the mobile cellular infrastructure around them, they've altered the way that we interact with ourselves, with other people, the way we date, the way we bank, and soon enough, the way that we will be providing mental health services. And so I hope to give you a glimpse of the things that my team and I and others have been doing, and maybe cast a bit of a vision for how the future will evolve. So to put some numbers behind these bold statements, if we're thinking about the UN's Telecommunication Union's estimate of mobile phone subscriptions worldwide, if in 2001 the estimate was around 1 billion, towards the end of 2017, the number was estimated at 7 billion. Now, the most recent numbers estimate that the number of mobile phone subscriptions is greater than the world's population. Now, of course, this doesn't mean that every single person on the planet has a mobile phone. What it does mean is that over 90% of the world's population is within access of a mobile cellular network, usually 3G and up, and that for the first time ever, they are able to reach people and resources in real time and in real place, and that we, or those resources, can also reach them in real time and in real place. So the potential healthcare implications of something like that are enormous. We are able to potentially break out of the brick and mortar clinic. It's a fundamental change in how we view assessment, monitoring, treatment, and ideally prevention. So you're all familiar with people with schizophrenia and psychotic disorders, and we all know that this is a population that often is marginalized, often has limited access to resources, limited education, difficulty with literacy in some cases. Access to these technologies may differ in this group. There are so many ways that people with psychotic disorders are different from the general population, and so does this apply as well to these broad numbers that we're talking about? And so to answer this question, back in 2011, 2012-ish, my team and I decided to survey people with serious mental illness in the greater Chicago area. Back at the time, it was 1,600 people with schizophrenia, schizoaffective disorder, bipolar disorder. The majority of that sample were people with psychotic illness. And so of the survey's respondents, we had over 900 people with schizophrenia. This was not an especially technologically savvy group. They were really representative of the type of folks that get services at community mental health agencies. And so average age, 47, the majority minority African American, 72% of them had a high school diploma or less, and the majority of them were earning $10,000 or less annually, Medicaid recipients in the US. So definitely a snapshot, a swath of the type of person that we think about when we think about people who live with the functional impairments that are linked with schizophrenia. And so we found that of that group, 63% of them, even back then, in 2011 and 12, and I say even back then because in the mobile health space, that is a lifetime ago, 63% of them had a mobile device. And the way that they were paying for them were linked to a range of resources. 25% of them were using what they called government minutes or Obama phones or Obama bucks. Oh, those were the good days. That was really the Federal Lifeline Assistance Program, right? It's a program that started from the FCC, originally meant to support people to have landlines so they can access things like emergency services and 911. In the 1990s, that was altered, so it also includes access to a mobile device, and depending on the state that you're in, anywhere between 250 to unlimited call and text minutes. So people were certainly capitalizing on that opportunity. People had month-to-month plans, 9% used prepaid cards, 10% had long-term plans, which is common among most people from a higher socioeconomic status. And in terms of uses of these devices, the majority were talking, a third were texting, and even back then, 13% were accessing the internet. So that means that they were using smartphones, shortly after smartphones really started hitting the market on a large scale. Now, as the penetration of mobile devices in the world increases, it increases in the same way among people with schizophrenia. A relatively recent meta-analysis by Firth and John Torres showed that of 15 studies, cross-sectional studies involving mobile health and psychosis, the data suggests that among samples that were recruited since 2014, 81% of people reported having a mobile phone. Research conducted in India shows that anywhere between 72 and 92% of people with schizophrenia there have mobile phones. And in fact, in a study that we recently completed, recruiting people who hear voices using Facebook ads, so again, this is probably a younger, more technologically savvy group, but among these people who regularly experience psychotic symptoms, 92% of them already have smartphones. So to answer that basic threshold question, do people with schizophrenia, do they own phones, do they use phones? Absolutely they do. And in a surprising way, it might be one of the areas where the gap between people with psychotic illness and the general population is close to non-existent. So there is a unique opportunity to leverage this status to try to improve what we do. Okay, all this sets the stage for really what the talk is about, and that is using mobile technology, primarily mobile phones, for mental health care. And so when we think about the kind of work that our group has done, we really try to capitalize on the natural evolution of the technology. So we build on things that already exist or reconfigure existing technology more than we try to invent new devices that essentially serve as medical devices but really have no utility outside of that. We try to capitalize on what people are already doing and interested in doing in the real world. And so at its lowest level of technological sophistication, we're really talking about leveraging mobile devices for person-to-person interactions as they were originally intended. So you can think of things like phone call interventions or texting approaches. And again, we don't create unique texting platforms. And I'll provide examples for this in a moment. But really, the idea here is to have a very, very low bar for entry. Use standard SMS. As we ascend up this evolutionary ladder of technological sophistication, that's when we start entering this world of leveraging some of the more sophisticated technologies, and we develop apps. And so here, this involves software that is often either accessed through web connectivity or installed on the device. And it's very clear that someone is involved in some sort of clinical interaction. It is very overt and visible, just digitized. And I'll give comprehensive examples for that in a moment. Now, in recent years, more and more, we've been moving into the space where the technology, the interventions, and the approaches become more invisible. And that's when we try to capitalize on things like sensors, wearable sensors, or the host of sensors that are embedded in smartphones. So to give an understanding of what we have sitting in most of your pockets, you have by far more computational capacity on your smartphones than NASA had when they sent the Apollo mission to the moon. Okay, and I'll provide some examples for that as well. So back to that low rung on the evolutionary ladder of technological sophistication. Here we created an approach called the mobile interventionist. The idea is to try to build on the human resources that we have out there working in the community, case managers who provide services for people with schizophrenia. And so the way that this works is that usually a case manager will reach out to someone with schizophrenia, conduct a home visit. There they will talk about the intervention. They will identify the treatment targets that are most viable and relevant for that person's life. It often involves psychotic symptoms, but not always the case. There might be a housing crisis. There might be medication adherence problems linked to symptoms. Once they do that, if the individual has never texted before, the mobile interventionist will train them right then and there in the room how to text. And we use intentionally this old flip phone because often these were the phones that we would find in the study. The study that I'm reporting on involves people with psychosis and co-occurring substance use. So that's a population that you know is quite difficult to engage in ongoing services. And so once they decide on their treatment targets, and the person has demonstrated that they know to receive messages and send messages, the intervention starts the moment the mobile interventionist leaves their home. They start with daily text messages and a ping-ponging, asynchronous but continuous conversation between the mobile interventionist and the client. Now, there's something very unique about text, and I still can't explain why this is the case, that it's okay to pick up the conversation the next day, exactly where you left it off at 6 p.m. the day before, in a way that you can't do with any other modality. Email never works this way. Phone calls never work this way, but it's fine to wait 48 hours, 72 hours, and someone will just respond as if they were right then and there, and people pick it up. And so what happens is, while the mobile interventionist is only available between 9 and 5, the patient might continue to send updates or questions after hours, and the mobile interventionist will pick up the thread the next day seamlessly. At the end of the week, the mobile interventionist will usually send a summary report. In this case, it's the form of an email to the team leader. And the objective here is to help inform the work of the in-person treatment team. In this case, it was ACT teams, Assertive Community Treatment Teams. Help improve what they do and inform their work with the daily updates from the texting approaches. So how does a text exchange like this actually look and feel? It might start with something. These are actual text messages from one of our studies. Hi, it's Sarah. How are you feeling, Ray? And so Ray responds, hi, Sarah. Voice is talking about me. And that's not surprising to Sarah because he identified auditory verbal hallucinations as something that was of constant distress to him. And so Sarah, this is taking place over several hours of the same day. That's stressful. Immediately, Sarah tries to normalize it. You are not alone. Lots of people hear voices. And Ray says, they say something bad. I'm paraphrasing here because of the spelling. They say something bad will happen if I take the bus. So now Ray is offering a very concrete target for intervention in a context, right? And so Sarah jumps into action. But voices make mistakes all the time. I have a trick that can help you test those voices. You can even use it on the bus. Do you want to hear about it? And Ray responds with a semi-enthusiastic, maybe. What is it? But that's the window of opportunity that Sarah's waiting for, right? She wants to be able to use the platform to create an opportunity for Ray to engage, in this case, in relaxation strategies, while Sarah is texting support in real time on the bus. And eventually, Ray wound up getting back on that bus, which we realized he was concerned that the driver was trying to poison him, and was able to get on with his life and visits to the community center. So in terms of outcomes, when we ran this 12-week trial, again, we recruited a very representative sample of people who had significant functional impairments here. So people with schizophrenia and schizoaffective disorder, middle age. At baseline, they had moderate cognitive impairments, moderate severity of psychotic symptoms, and moderate depressive symptoms. 80% of them, remember this was an ACT team, right? So 80% of them were hospitalized at least 6 or more times. So certainly people that we know can have a deteriorating status. 59% of them were living independently, and so a fair amount of them were in some sort of assisted living facility. Now, only 47% of them reported having any experience with texting. So they learned that texting approach in that 1-hour home visit with Sarah. In terms of feasibility, we had 0 dropout. That means that every single person who started the study completed it, which, as you all know, is practically unheard of, right? It must be false, right? The data might be corrupted somehow. They received, on average, 139 text messages. The response rate was 87% to those messages. And in fact, when we administered a satisfaction measure at the end of it, the majority thought it was easy to use, that they would recommend it to a friend, that it helped them have more control over their lives. And in terms of clinical outcomes, we used text to identify instances of suicidal ideation that were not reported to the treatment team. And through aggressive outreach by the mobile interventionist to the patient and the treatment team, those individuals were stabilized. We had one woman who reported not having medications, not sleeping, not eating for several days, a pattern that was very similar to a previous pattern before she wound up in the hospital, and she was stabilized. And in terms of pre-post outcomes, we found reductions in psychotic symptoms and reductions in depression. But that really wasn't what I was interested in that study. What I was really curious about is, given the disembodied nature of this interaction, can we even create a meaningful therapeutic relationship entirely via text? Remember, they see this mobile interventionist for the first time once at the beginning of a 3-month intervention period, and from that point on, everything is through text. And so I was really skeptical that we would be able to create this type of positive therapeutic relation. I'm trained as a clinical psychologist, right? So I believe in the healing power of connection and facial expressions and engagement and body language and the human touch to things. And so we administered the Working Alliance Inventory. It's a measure of the strength of a therapeutic relationship twice. We ask our clients to rate their in-person treatment team once. In some cases, these were people that have been seeing the ACT team for the last 8 years or so. And a second time to rate their mobile interventionist. Now, the ratings for both of them were good. The ratings for the mobile interventionist were significantly better. So we were definitely able to create a therapeutic relationship entirely via text. So for those working in our healthcare system, HIPAA, right? So to address some concerns that people might have about the patient privacy and data security issues involving text, the director of the US Department of Health and Human Services Office for Civil Rights, that's the agency that's in charge of enforcing HIPAA, has come out with a statement saying that healthcare providers are allowed to share patient health information with their patients through standard text messages, not encrypted, layered through app messages. You're allowed to use standard open SMS in the same way that we would get the type of consents that we would get with email. Providers must first warn their patients that texting is not secure. They have to gain the patient's authorization to do that and document the patient's consent. But once you have that, which are the same type of barriers that you have to engaging people in receiving emails with confidential patient information, you are good to go from a HIPAA compliance perspective. Now, what happens at the agency or healthcare system level, that's a different story, right? There you have compliance officers and layers of people contemplating whether this is secure or not and consistent with the healthcare system. But the reason that I have this very wordy slide up here with a link is that people can also advocate for this internally. You can start providing services tomorrow from a HIPAA compliance perspective at the federal level. Okay. Let's move up into the more sophisticated technology, and that's where I'll tell you a lot about a mobile health system that we've developed called Focus. It's a smartphone app that was originally designed for people with schizophrenia, but since then has been tested with a range of people with serious mental illness. And luckily, this was funded through multiple grants through different funding agencies, so we've had this opportunity to improve and refine and deploy and refine Focus again and again and again, and really follow this over time. And so initially, this started with the client survey, that one that I was talking about, penetration of mobile devices. We also attached questions about inquiring what patients with schizophrenia would be interested in us targeting with a potential smartphone intervention. We also interviewed practitioners and asked them, what are the areas where you seem to not be able to break through or can use additional support? What are the hot topics for you? We also spoke with C-suite CEOs, CFOs of community mental health centers, our intended partners for these types of deployments, because we know that if you can develop a technology that is very sexy on paper and functional, but if the healthcare system does not want to use it or cannot use it because of built-in barriers, you are not going to get traction. And so it was very important for us to engage the leadership level from the beginning. Once we did that, we assembled a multidisciplinary team of clinicians and technologists, created the content, evolved the platform. And so eventually we converged on an Android-based smartphone app, and then did lab-based usability testing. So we applied user-centered design. We brought people into the lab. We gave them wireframe ideas of what we're thinking of doing. They would respond both in conversational feedback, but also you learn a lot from the facial expressions, from the moment when someone seems stumped, when the moment someone stops, and we're videotaping everything. And we use that information to inform and streamline our intervention again and again and again through multiple cycles. So ultimately, we arrived at the version of Focus that we have today, and I'll tell you how this thing works. It has several functions to it. There are up to 3 daily prompts, and I'll show you how a prompt looks in a moment, but essentially it takes over the home screen and starts asking assessment questions that are relevant for that individual during that time frame of the day. In addition to these prompted interactions, there are also on-demand resources. Everything that the app has to offer is installed on the device, and once it's there, regardless of whether someone has internet connectivity or good reception, they can access everything 24/7. So the 5 general treatment targets that we have in Focus are voices, or coping with auditory hallucinations, social functioning, which is really a combination of social skills training and content focusing on coping with persecutory ideation. And Focus works almost like a choose-your-own-adventure book that, depending on the responses that you have to certain questions, it will take you down a different intervention route. Medication use, which doesn't just mean medication adherence. It also means empowering people to have conversations with their prescribers about things like concerning side effects, or questioning whether the medications that they're taking are in fact the right medications for them. Sleep, not a core symptom of schizophrenia, but time and time again in our interviews came up as an area that we know is either an early indicator of people not doing well or a consequence, and once people are fatigued, everything goes downhill from there, right? It exacerbates everything. And so we realized we need to add sleep hygiene into this thing, and mood, which really means depression and anxiety content. So if Focus takes over the home screen, it'll ask, can you check in with Focus right now? If the individual says yes, it'll immediately launch into the assessment of the area that was deemed relevant at baseline for that individual for that time of the day. In this case, hello, Rachel. We try to do some personalization to things. Have you been bothered by voices today? With the multiple choice response options. And so Rachel, in this case, says moderately. Now Focus knows it needs to dig deeper into the dysfunctional beliefs that Rachel might have about her voices. Do you think that the voices can't be controlled? They know everything, they're powerful, they're unpleasant, or something else? And there is a rotation in the themes that might appear in Focus so that people don't always see exactly the same thing. That's why we have the other option. In this case, Rachel thinks that the voices know everything, common. And so now Focus starts with the intervention. Voices may sound like they know everything, but they don't. Can you think of any time when the voices made a mistake? How about when the voices were sure something was going to happen, but it didn't? If the voices got it wrong once, they probably don't know everything, right? Think about it. And the idea here is to give quick and dirty tools for people to manage these dysfunctional beliefs in the moment. Now, if you look at the screen and the functionality of Focus, it is intentionally very, very simple. You cannot navigate back. There are no bells and whistles. There were a lot of things that existed in the original versions of Focus that our user-centered design taught us, drop this. This is appealing to you as the researchers and the technologists. Patients are losing their place in this. When you have distraction, when you have salient psychiatric symptoms, you don't need additional places to get lost on the device. You need to be able to navigate to where you need to go. And ideally, the language is at a 6th grade reading level, usually no more than 1 sentence or 2 per slide. All intentional. Now, in the current version of Focus, there is a parallel version so that all the written content can also be accessed through video, because here we're really trying to capitalize on the multimedia capabilities of the smartphone, right? Otherwise, we're just taking a treatment protocol and we're slapping it on a device. And so people often elect, usually when they're in private settings, to launch a video. And if they do that, they might be, in response to the same questions that you just saw, they might see something like this. Voices make mistakes all the time. Try this experiment to test your voices. Ask them to make a prediction about the color of the next 3 cars that you see in the street. Write down the colors and the order that the voice is saying. Now, test it. Are the next 3 cars exactly in the same order of colors that they mentioned? If they got it wrong, think about it. What else could the voices be getting wrong? Their predictions are not always right. So they have an arsenal of these tools that are sitting on their device that they can access and rotate through. We usually find that after several weeks of using this, people tend to gravitate towards the same interventions, especially when it comes to mood. They tend to use the same types of relaxation strategies if they have anxiety. And what we try to do is link this to things that are immediately relevant. We try to capitalize on the fact that people are using the device in real time, in real place. So when there's an opportunity to integrate an exercise like looking out the window and counting cars, we do that. We don't try to give something that is the equivalent of a 50-minute session on the phone. But we do this multiple times a day, multiple days a week. All the data from those assessment questions, those initial questions about are you experiencing symptoms and functional impairments and what is the nature of that, that is uploaded when we have internet connectivity to a remote clinician dashboard. And so authorized individuals can access this information, and they can see anything from their response rates over the last 7 days, the 3 treatment targets that were assigned to that individual, the relative severity of their responses, and for the really motivated clinician, there's a response log. So you can track all the reactions and all the responses since the moment they started the intervention to monitor change within individual over time. Okay, does this work? Right. In the initial 30-day trial of Focus, again, we recruited a representative sample, and we found that over a 30-day deployment, patients used Focus on 86% of the days that they had this. We don't incentivize, by the way, participants to use the smartphone intervention. We usually pay people for assessments, but the amount that they use the device is entirely up to them. They're free to not use it at all. And so they used it on 86% of the days that they have it. During that first week of that initial monthly trial, on average 6.4 times a day. During the last week, 4.9 times a day. If you recall, we only prompt them up to 3 times a day. And in fact, 2/3 of Focus use was completely elective and on demand, not responding to prompts. We administer usability and feasibility measures at the end of that deployment, and we found that the majority would recommend it to a friend. They did not think it was complicated. They thought it was easy to use. They thought it was interactive. They felt confident using it. They didn't need to learn a lot of things to get up and running, and it was easy to find the information that they needed. So our user-centered design approach, while more laborious on the front end, certainly paid off. Clinical outcomes, we saw the type of reduction in psychotic symptoms and in depression that you would hope to get from clinic-based care. But these preliminary findings are not compelling enough for us. We needed to continue to test to see how this really matches against clinic-based care, and I'll get to that in a minute. So since then, Focus has been used quite extensively. This is the summary of a 6-month project that was funded through CMS. It was a multi-component effort led by John Kane, and Focus was one of the technology tools that we deployed among people with schizophrenia who were recently discharged from a psychiatric hospitalization. It was a large study, 340 individuals, and we found, interestingly enough, that the same type of demographic variables that predict engagement in clinic-based care seem to play out in how people used Focus. So female participants, on average, engaged more than males, 0.4 more times a day. White participants seem to engage more than African-American participants, 0.7 more days a week. And older participants, 30 and older, engage more than younger participants, which was a little surprising to us. But these are exactly the patterns that we see in clinic-based care. Overall, though, when we're thinking about the engagement with Focus, whether we call that days of mobile health use, days responding to prompts, days of self-initiated on-demand use, or daily on-demand use, we found that the red line represents 44% of the sample that used Focus continuously for a 6-month period. Now, if you compare that to the average shelf life of an app, I don't know if people know this, the average use events for a new app that you download onto your smartphone is 1 time. So clearly, people found clinical utility in this approach. But that toe-to-toe comparison, right? How does this really play out against the alternative that exists in clinics? And so with funding from the Patient-Centered Outcome Research Institute, we conducted a comparative effectiveness trial. We randomized people into one of two arms, either the focused intervention or WRAP, Wellness Recovery Action Planning. That's an evidence-based group intervention delivered at clinics with all the characteristics that you would typically think of a group intervention. So 2 trained facilitators, a 90-minute session, groups that are anywhere between 6 and 10 people once a week. To cut to the chase, we found no significant differences in the clinical outcomes or satisfaction ratings between these conditions. They both produced small to medium effects, but they were indistinguishable, even though these are dramatically different treatment modalities. And in fact, the real kicker was here. Right after randomization, we measured treatment commencement, because we know that for many, many people with schizophrenia, the barrier is starting with treatment. At that stage, people don't really know what is going to be the content of focus or the content of the WRAP rooms. They just know that they're either called in to install an app on a phone and that the majority of the intervention will be conducted remotely, or they know that they're going to come in and meet with a facilitator and start clinic-based care. 90% of the people who are assigned to the mobile health arm make that move, which also required some movement. They were both ambulating to the same extent. They needed to come to the clinic and get set up and trained on focus. 90% of people did that, whereas only 58% of people in the WRAP arm ever made it into the clinic for a single session. We lose close to half of our target audience right then and there when we ask them to come to the clinic. And that superiority of engagement with focus was maintained regardless of the dropout rates throughout the study, throughout the 3-month intervention period. In terms of clinical outcomes, both produced reduction in BDI, Beck Depression Inventory scores at 3-month and 6-month follow-up. Both produced similar reductions in general psychopathology. Both produced similar improvements in recovery as rated by the Recovery Assessment Scale. And when you look at the satisfaction ratings, items like I'm satisfied with the treatment program, I enjoyed the treatment program, I would recommend the treatment program to a friend, they are practically identical. Now, the most recent finding that we just summarized is we were interested in examining the impact on other services by those same treatment centers. So we looked at the service use minutes in the 3-month period before treatment, during treatment, and after treatment. Black line represents before treatment. And so we see that there was a 9% reduction in other services used during the treatment period for people in the focus arm. And that was actually a 12% reduction among what we labeled as treatment responders, people who experienced significant reduction, improvement in recovery that was sustained at 6-month follow-up. So we had a higher bar for those individuals. Among them, 12% reduction in other services, and an additional 12% reduction in the follow-up period, where they weren't getting focus anymore, which suggests that they, in fact, internalized a lot of the skills and strategies during that 3-month intervention period. Okay. The exciting news is that we're kicking off a large statewide implementation of focus in Washington State. It's a project that's funded through the National Institute of Mental Health, and it's a partnership between the University of Washington and Medicaid, Washington State Medicaid. We are deploying focus in partnership with 20 community mental health centers, and currently it stands to be the largest mobile health for serious mental illness project ever conducted. So we're kicking that off now. It's complicated. We're testing 2 implementation approaches, but everyone's going to get the mobile health intervention. And so I'll be excited to come here in a few years and tell you about our successes or failures. Okay, on to the last frontier in terms of technological sophistication. So this is where we move into that area of sensing and signal detection. We deployed, with some support from the NIH's Eureka program a few years ago, we created and deployed a system called Crosscheck. Now, what that does, it collects self-report data administered on the device, similar to Focus, but also captures everything else that's being used on the smartphone. And so we look at the apps that people are using, we look at their phone call logs and their text messages without actually looking at the content. So we'll look at the frequency and duration of calls. We don't capture the spoken word. We also activate GPS, microphone, accelerometry, all this to try to identify the behavioral traces of how someone is behaving in real world. All that is uploaded to a server where it's processed on the back end and is available to us on a dashboard with an attempt to try to identify the early warning signs, the red flags. So how does this work? Our system reconfigures the use of the GPS, same type of technology that we all use on our smartphones to navigate. Well, we leverage that data to determine the distance that an individual covers throughout the day, and also the time that they spend at a particular location. We never actually cross-reference what that location is. We don't use the GPS coordinates to label it, other than location, primary location, secondary location, tertiary location. Usually primary location is where people spend their nights, where they sleep and spend most of their day, especially if they're not employed. When we deployed this in New Hampshire hospital, we couldn't get GPS pings, right, because people are indoors, but we wanted to see whether there was a relationship between the location of someone on the inpatient unit and violent ideation. And so we outfitted the entire unit with Bluetooth beacons in every room. And so as people were moving through space, the device would get pings from the Bluetooth beacons, and the strength of the signal would tell us where they were when they were having certain thoughts that they were reporting on the device. So there are nifty ways to get at this, right, at their geospatial activity. We use accelerometry with Google API to determine someone's kinesthetic activity, whether they're walking or running or cycling, but more importantly from our perspective, are they sedentary, the proportion of sedentary time, because we know that that's linked to so many health variables. We'll spark up the microphone every 2 minutes or so to capture ambient sound, and we'll run speech processing software to determine conversation turn-taking activity, conversation frequency, and conversation duration. Again, without ever recording the nature of the conversation. That's important from a patient privacy perspective because people would not want you listening to their fights with their spouse or conversations with their drug dealer. We'll use a combination of sensor streams to try to infer their sleep. So things like their device use, light sensing, sound. Now, of course, if someone naps on a sofa in midday with the TV running, that messes up our data, right? We're not as accurate. But with people who usually sleep in a darkened room, so long as they have the device in the room with them, we are within 30 minutes of self-reported sleep duration for that night. So when we deployed this in the context of the Crosscheck study, it was a 1-year deployment. People with schizophrenia recently discharged from the hospital, and I'll describe 3 cases. Blue line represents a psychiatric hospitalization. It's the very relapse event that we're trying to prevent. And we had a list of them: suicidal ideation, hospitalization, arrest. And so the black dots here represent their self-report composite scores. The higher the dot, the better people are doing, meaning they're reporting less symptoms and greater functioning. So for weeks, we see that this person certainly has some fluctuations, but overall is within the 0 to 15 range, right? And so there are changes in things. However, here, there is a drop right before that hospitalization. That person has good insight. They are aware that they are experiencing increased symptoms and functional impairments. It shows up in their self-report, and boom, they do wind up in the hospital. After a relatively brief hospitalization, they are stabilized, they're discharged, and gradually we see their self-reported composite scores ascend back to where they were. So in this case, all the fancy sensing was not necessary, right? We were able to just ask people, how are you feeling and what are you doing? And they were pretty good. That doesn't fly for everyone. And so this other patient, if you look at their composite scores, they're flatlined. So either they are really stoic and unchanging, or they are blasting through our questions because they don't want to engage with these questions again and again and again. And so they're giving less meaningless answers. The sensors tell a different story. So if you look at the bottom section of this, this represents the hours that they spend at a primary location. And so there are certainly changes, in this case, 10 hours to 14 hours, and different changes throughout the day. Here there is a segment where they turn off their GPS. So we go dark. And so that's where the RA calls and says, you know, we really need you to turn this on if we're there to help. All this is done in a very overt manner, right? We're not a spy agency, right? We all do this in partnership, and the objective here is for people to know that we are hovering in the background looking for the opportunities to reach out to them when we think that there's a sign that they may be struggling. And so once they're back online, we see these changes, and then lo and behold, something happens here. There is a dramatic change. This doesn't represent not getting data. This represents their hours in primary location, right? And so here we know that this person is no longer living where they were living. So whether they've moved or there's a housing crisis, we can't tell, but we know that the sensors are definitely indicating to us that there are pretty dramatic changes in your life preceding that hospitalization. So the last example that I'll give of another case, because different sensor streams tell a different story for different individuals, here is device activity between midnight and 6 a.m., the times that we're expecting people to be asleep. And so we see that some nights, there's a lot of activity. Keep in mind that once someone launches an app or does a search, the device does not go dormant immediately when they stop searching. So we might get traces that last for longer. But there are certainly nights when they're not using their device at all. But here, there's clearly a change in their nighttime activity. And that goes on for several weeks and a long hospitalization. Once they're discharged, they're back on track. And so here, without asking any questions, the device activity, the sensor streams indicating use, really tell a compelling story. The one thing that we realized, and this is a recent paper from my postdoc, Ben Bach, the really compelling story is what we find cutting across individuals. And we found that in the 30-day period prior to relapses, their digital socialization, their digital social functioning, as indicated by outgoing calls, duration and frequency, and outgoing text messages drop in the 30-day periods preceding hospitalizations. And so we're getting eyes on a new type of indicator of social functioning. And this was just done in schizophrenia research. Okay, so how do you actually make sense of all this stuff? We've got the host, we've got this mess of sensor data, right? Sensor streams, very difficult to come with some sort of a priori hypothesis about what we're expecting to see. We certainly have indications that different things appear for different people. So our model is not to try to identify this thing that cuts across everyone, right? We don't view this as a homogeneous group or a consistent problem that represents itself in the same way. What we're looking for are anchors, relapse events, a hospitalization, self-reported suicidal ideation, the kind of thing we're trying to stop. When we have that, an objective indicator of that, that's when we go through the period preceding that event, and that combination of sensor streams, those anchored sensor streams, become that individual's relapse signature. And each individual will have their own relapse signature. So as we continue to collect data over a 12-month period or longer, because this is a relatively low burden activity, we're not blind anymore, we're hunting, right? We're hunting for something that looks similarly anchored. And when we find that, the next time around, we're not so passive. We raise the red flag. And so what does that mean? That means on the one side, reaching out to the patient themselves with feedback, indicating, Joe, if have you been in touch with your clinicians lately? Are there things going on in your life? Can we assist, right? Time sensitive, high intensity, but low frequency outreach. And if we're authorized, we will also reach out to their treatment team based at the hospital and say, if you haven't been in touch with Joe for a while, now might be a good time to reach out or do a home visit, because there are digital traces that are awfully similar to the last time that he had some trouble. Okay, where is all this heading? So right now, the spot that we're really treating people and the way that we're thinking about mobile health apps is all the way down at the relapse prevention phase, right? So this is when people are already are getting services or not. They already self-identify as having illness. They're involved in our studies. We can talk about symptoms, and that's where we do things with the active self-monitoring, the self-management app, the passive sensing, but the opportunities for intervention are way further upstream. We know that parents with psychopathology or substance use or domestic discord are fertile ground for psychopathology, right? We know that there are softer signs of illness at the prodromal phases. We rarely catch people at the first episode period. And beyond where we're intervening now with our relapse prevention efforts, there's also a real opportunity to focus not only on the weaknesses in symptom management, but on strength-based approaches, building the strengths, continuing someone's path in recovery with vocational rehabilitation, housing support. So we're only starting, really, with the opportunities for mobile health. And I really encourage you to think creatively about what we can do in this space. So the last point that I'll make, which is a combination of sort of vision and advocacy, I think, is as we're gearing up to do this large implementation project in Washington State, I can't help but think about low and middle income countries. And so there we know that all the challenges that we know people with serious mental illness experience in the United States and other well-resourced countries are exponentially greater. In fact, if you think of a country like Ghana, a country of 26 to 27 million, with approximately 26 psychiatrists. So the vast majority of the population will never get the type of treatment that we are trying to gear up towards from the providers who are the product of medical schools or clinical psychology doctoral training programs. They do get services from healers, 45,000 of them, traditional and faith healers. And so I thought I'd share with you this quick video that we shot in Ghana to give you a sense of the opportunity there.
How long have you been here?
3 years now.
3 years?
Yeah.
3 years right in this room?
Yeah.
Ghana, like most of West Africa, is facing a real mental health crisis. The gap between the enormous need and services is filled by traditional healers and prophets and other spiritual advisors. Oftentimes, this treatment comes with a host of human rights violations.
Mommy, don't leave me. Oh, mommy. Mommy.
We see people who have behaviors that are just difficult to contain, chained to trees or to concrete slabs in prayer camps for days, weeks, months, and even years at a time. Forced confinement, forced fasting. They're not doing it as a punitive action. Even the traditional healers who engage in these practices are extremely interested in alternative solutions. In West Africa, there may be a gap in terms of access to mental health training and mental health resources, but there's certainly not a gap when it comes to the penetration of mobile devices. My area of research is mobile health tools in the study, assessment, treatment, and prevention of mental illness. Adopting the models that we used in the United States, I can easily imagine developing tools that are patient-facing, texting interventions or smartphone apps that provide resources that are easy to understand using simple language or video, stigma-busting content, and practical skills to manage distress. things that might support the providers, individuals who go out into the field and who might not have the training and expertise to manage complex mental health conditions. We're moving less and less from written interventions into audio and video-based interventions, and those are accessible to everyone. Keep in mind, half of the people that we showed this to, half of the traditional healers, were illiterate. When we talked to them about trying to leverage their personal mobile devices as an instrument to get some sort of support that would allow them not to engage in these practices, across the board, they were remarkably open and interested in this. We've really seen an enormous amount of enthusiasm for the type of mobile health for mental health work that we do. The types of tools that we've developed in the United States can't just be taken and plopped down in the region. There needs to be contextual influence. We need to understand the appropriate languages, the behaviors. Ghana is the ideal setting for this first foray into this world. I think that the will is there. I think the capacities in terms of the technology is there. We just need to do it. Folks, thanks so much for your attention and your time, and I'll take a few questions.
Questions?
Thank you for a very interesting talk. So my personal phone's still a flip phone, so I may not be the best early adopter, but most industrialized countries have recently experienced a lot of external intrusion into both devices and electronic media, and in our elections and other sorts of things. What have you thought about, and what can be done about preventing that in this sort of platform?
So I think that's a valid and powerful concern. It's just not necessarily my program of research. So I think that there's certainly, in terms of introducing a new resource or asset in any context, there are always going to be opportunities for good use and counterproductive outcomes. I think that's true for technologies like smartphones and social media penetration. It's true for technologies like ATMs. So it's not to minimize the problem, it's just to say that I don't know, let me rephrase this. Whether people use technology or not to support their mental health care is largely out of our hands. And so humans are clever, and they find ways to use the resources that are at their disposal one way or another. A good example for that is research showing that people will use resources like YouTube, a publicly available video website, to post testimonials about their psychiatric illnesses, things that I thought I would never see in my lifetime, where people overtly talk to an open community about the experience of voices and persecutory ideation, and use the comments section as a virtual community to support their use. So in my mind, the question is less, do we try to leverage technology to improve mental health outcomes or not? It's rather, people are already voting with their feet. They will find ways to use things that were never originally intended to do this. And the question is, from my perspective, how do we channel the energy and the science behind this to give them the best options possible? Yes, please.
First of all, great talk, and you're my hero. I'm not really surprised that they found that therapists who were doing the texting so kind. We've actually used a machine that had no therapist to remind them, to take their medicine and saying good job, and they actually assumed it was a person and personified it and really liked it and felt like someone cared about them even though there was no person there.
So that's funny you mentioned that. That's exactly how I came. I'm a bit of a technophobe at baseline. I'm a technophobe myself, but in graduate school I was doing ecological momentary assessment research where we were giving the cutting edge technology of the time. It was Palm Pilots, if you remember those, with the stylus and the responses. And so what we found is that people with psychopathology, that we would send these prompts with questions about their anxiety and their depression multiple times throughout the day, would come back to the clinic, to our lab, to return the devices and receive payment. And then they would say things to me like, thanks, doc, this really helped me, or thanks for looking out for me this week. which from a methodological perspective was a real problem, right? Because I was inadvertently unintentionally affecting their mood. But at the same time, what stuck with me was, if we're getting these outcomes when we're not even intending, what happens if we actually put our minds to it? And flash forward 15 years or so, and this is what I devote all my time to. Maybe last question over here.
Hi, thanks for the talk, nice talk. I'm Alexander Law from Brazil. I run a prodromal cohort, and we see that many people, they, like you showed in Africa, they seek the healers, in Brazil more like spiritualized leaders, and many people actually don't convert to psychosis or to any mental disorders. So based on what you've shown us, do you approach when you're dealing with prodromal cases, do you approach this in a psychological framework, or do you use, for instance, the religious approach that they use in Africa?
Yeah, so if you're asking specifically about the model in Africa, there really the project is at its earliest phases, and we're developing the partnerships now. The first stage was really to examine the openness and penetration of mobile technologies in the healers. And there's a very complex political landscape there, because really everyone knows that this is the state of affairs, and at the same time the government does not officially condone these, and in fact once in a while does these cosmetic gestures of shutting down a prayer camp. And so there's this cat and mouse, there's the cosmetics of it, and there's the reality of it, where we know that also periodically the police in a certain region will bring people to these prayer camps where they endure these human rights violations in many cases. And so there, absolutely part of the model will not be to try to say, let's train you on CBT for psychosis, but rather try to integrate the language that everyone speaks, that is a highly religious country. The majority are Christian. Up north, there's a more Muslim presence. But we know that government meetings start with prayer. Any visitation to someone's home starts with some sort of religious ritual before dinner. And so that is part of the idea, is how do we integrate parables and ideas from Old Testament and New Testament to help inform some of the things that may cut across. And so you can phrase something as a relaxation strategy, or you can phrase it as connecting with your elders, or thinking about your place, your place in the spiritual world. But the concepts and the overall formats are similar. It's just the presentation that is a little bit different. Folks, thanks so much. I hope you enjoy the rest of your conference.
Thank you. Let's thank Dror for a fantastic lecture.